moving right into our very first session, which looks at what the best HIEs are doing out there with Erica Galvez of Manifest MedEx and Mickey Yalon of J2 Interactive with Jim Tate, host of the Tate Chronicles on our Healthcare and Radio station, who will be asking the questions. So Jim, Mickey, Erica, I'm turning it over to you guys.
Well, thank you, Carol, for that. Welcome, Erica and Mickey. We've got a lot to cover, so we may not get to everything, but we're going to get to as much as possible. First, let me say, just as an overview, in my experience, interoperability is a destination, but it's also a process. I can remember when we defined interoperability as somebody coming to see their provider with paper records in their hand. We thought that was great. And then we had fax machines. We thought, okay, we're getting somewhere now. So we are building towards, of course, a more electronic, shared exchange of data and everything that goes with that. First, I'm going to ask you, Erica, I know with your work with Manifest MedEx, really you're taking the lead on new industry standards and regulations like TEFCA. So could you talk to us a little bit about that? And Mickey, then we'll let you weigh in, please.
Yeah, Jim, thank you. And thanks for inviting Manifest MedEx to the conversation. It's a privilege and an honor to be with you all today. Manifest MedEx has a number of things in motion right now that relate to TEFCA, and I would say really extend beyond TEFCA. We partnered with eHealth Exchange as our QHIN for TEFCA services. That was an easy decision. We've been a longtime participant in eHealth Exchange, and so look forward to completing that process at the end of this month. At the end of Q4, we should be fully onboarded. In parallel with that, I would mention the data exchange framework in California, which is designed really through legislation to require health plans and providers to share information, and encourages other components of the care delivery system like counties within the state to participate in that as well, with an eye towards some very ambitious Medi-Cal goals and transformational efforts across the state. The data exchange framework addresses not only health information, but it includes this acronym HSSI, Health and Social Services Information, intended to really build bridges between the clinical care delivery system, social supports within communities, as well as public health. I would say it builds from a foundation that I think TEFCA enables, but extends well beyond that, given the goals that the state is trying to achieve. It requires sharing of ADT data feeds, for example, for notifications. I mentioned social services information. There's a whole shift and, in fact, a roadmap that's out for public comment. I think that may have just closed around the inclusion of social information, again, to support that kind of building of bridges. Maybe the last thing I'll mention is there are 9 qualified HIOs that have been designated to support the program. The legislation is technology neutral, or technology agnostic, I should say. There's no requirement for organizations to participate in a qualified HIO or to use a specific product or service or technology platform. But there is a robust set of organizations, including Manifest MedEx, that support the community and the stakeholders across the state in compliance.
Mickey, your thoughts on that?
Yeah, thanks, Jim, and pleasure to be here as well. I would say our experience working with many HIEs throughout the nation is similar to what Erica has described, and a little bit what Mickey Tripathi was talking about, right? So most of the HIEs we work with have been connected to one or more of the national networks for years, right? eHealth Exchange, Commonwealth, Care Quality, right? Many of them are using those existing connections like Manifest MedEx to access TEFCA, right? And a few of them are either already or in the planning stages of becoming QHINs themselves. So I do think that although TEFCA has only been really enforced for about a year now, there is a lot of momentum behind it because it's built on the national exchanges that were already there and already used by the industry.
You know, we're talking about data coming out of those HIEs for patient care, but also there seems to be some fantastic potential for all that data to be used for public health, for policy development, and those resources, you know, are incredibly important. Could you speak to that a little bit, Erica?
Absolutely. I can give you our California experience
Right.
and some depth on that. Manifest MedEx actually started a couple of years ago, serving as the infrastructure for the California Department of Public Health's electronic lab reporting requirements. In other words, we wire up over 400 labs currently and take in lab results for reportable conditions, do some uplift on that, and pass that on to CDPH for use in the public health enterprise. We expanded that to electronic case reporting about a year or a year and a half ago. I think HIEs are, in many cases, uniquely positioned to serve as that kind of partner for public health, both at a state as well as a local level, because of the depth of expertise around data standards, existing connectivity, the ability to build out new connectivity quickly. Maybe I'll also mention at the local level, we do things like partner with local jurisdictions to address communicable diseases. Congenital syphilis has been something that we've supported notifications around so that proper treatment can be provided in a timely manner for folks expecting babies. And tuberculosis is another condition that has come onto our radar recently. So I think lots of possibilities for partnership and support between HIEs and public health. And I'm sure Mickey has other thoughts on that as well.
Well, you know, Mickey, one thing I wanted to ask you specifically, when you and I were talking, maybe sometime last week, we talked about how HIEs, the specific scenario of Hurricane Helene in North Carolina. Could you talk about that a little bit?
Yeah, certainly. So, I mean, obviously HIEs have always been sort of on the front lines of public health and public health reporting. We have one of our HIE clients that is the North Carolina HIE, right? Statewide HIE. And as part of their response to Hurricane Helene, the North Carolina Medicaid actually reached out to the HIE because they were worried about all their members and the welfare of those members, and they actually reached out to find out, had any of those beneficiaries had an encounter over the course of the emergency, and if so, they realized they needed to follow up with them and do wellness checks with those existing beneficiaries, right? So it was an interesting sort of case where public health was reaching back into the HIE and using the information the HIE had access to identify members who were in need and then actually follow up on that. So very, very interesting case. Similar case happened in Houston, Hurricane Harvey back in 2017. Another one of our HIE clients, Greater Houston Health Connect, had a very similar response, right, to the emergency there. So there's a lot of good that HIEs can provide in those emergency scenarios.
You know, we're talking really about best practices of HIEs. And it's not until some event occurs and we see how the foundational HIE domain is working. And when it doesn't work, that's also something that we know where things need to be done. I'll give you an example. Of course, during COVID, we didn't, at the highest level, the government had trouble getting the data to know who tested positive, who had immunizations. So one way to develop best practices is when we encounter something like that. You mentioned North Carolina after Hurricane Helene. They were able to come up with creative ways to use that kind of going backwards, to check on patients. But as things develop, we also find out where there are gaps. that need to be improved upon moving forward. But enough said about that. We're seeing more and more HIEs talking about getting involved with CBOs. And so, being able to partner with CBOs to really help solve various social determinant of health issues. What are your thoughts about this, Erica?
Yeah, it's certainly relevant for us in California. I think as we look at achieving the outcomes, the health outcomes that we all want to see and the progress toward those, we inevitably have to look at the 80% of health-related factors that sit outside the traditional care delivery system.
Yeah.
And so it pushes those of us in the HIE world in particular who have really focused on clinical connectivity in the clinical care delivery system to think broader and to think about how we bridge outside of a HIPAA universe, right? Because many of those CBOs are not, they're not HIPAA covered entities. In some cases, they're not business associates of HIPAA covered entities. And so this requires us to enter a space that I think is uncomfortable sometimes, but absolutely necessary.
Mickey, your thoughts about that?
Yeah, I mean, I think that, CBOs are sort of the new forefront of where HIEs and traditional healthcare are intersecting with all of the supportive services that exist out in the community, right? So we have a lot of our HIE clients who are actively participating in one manner or another with social services, right, and doing closed loop referrals as part of their social service support. We also have some of our customers who are actively working with their state Medicaid departments to get access to social services data and get access to social determinant of health information like HRSNs delivered back to the Medicaid so that Medicaid can do their outreach and provide impactful sort of services around that. So I do think it's a really critical point we're at right now. And as HIEs go beyond traditional healthcare data and into the social determinant of health realm and into supporting social services, I think the impact they have on their community is even that much greater than it has been.
Of course, one of the buzzwords the last 5 years plus has been FHIR. So let's talk about FHIR a little bit. So obviously there's a need to really streamline how clinical data is made available and exchanged. For years and years, certified EHRs could create and export and import and reconcile CCDAs, but those are giant clumps of data. If a provider just wanted to know medication allergies or procedures or implanted devices or things like that, there was no way to go after that specific data. So with a certified technology, EHRs now, this year, by the end of this year, having the requirement to have that FHIR capability to export data in a or make data available in a FHIR standard. That's great, but is it actually being used? And so first, let me go to you first, Mickey. Can you give me a little bit of the history of the FHIR standard?
Yeah, I mean, obviously, Mickey Tripathi did a nice, sort of overview from the standards, standpoint of sort of the history of some of the things that led to the FHIR standard. But I mean, I think it's worth saying we've been talking about FHIR for a long time, right? It more than 10 years now, right? FHIR has been the next big thing in healthcare exchange, right? So really going back to 2014, right, when the original draft standard, became available. What we see out here in the real world, if you will, as opposed to the standards world that Mickey is very much pushing the boundaries on, is there are certain use cases, and I know Erica can speak to some of the ones that Manifest MedEx is involved in, where FHIR is is available for use, is better than the alternatives, right? But not entirely sufficient to solve all of the interoperability challenges that that organizations have, right? So yeah, I do think FHIR is a great tool. I think it's one of the many tools we have in sort of delivering this high quality of data across the whole healthcare continuum. Yeah, I think it will continue to build on the momentum it already has, and there is a lot of momentum there, and there's some really exciting stuff that's coming down, you know, sort of the track with some of the industry FHIR, what they call IGs, implementation guides, right? You have organizations like Da Vinci that represent the payer community that are looking at how they can use FHIR to streamline their data exchange. You look at things like the Gravity Project, which is focused on how to use FHIR to exchange SDOH data and support the CBO community. And there are many other of these sort of public-private partnerships that where FHIR is the sort of language that is enabling these organizations to look at the future of healthcare and imagine something that, you know, very soon now, but maybe not quite, will get us to the level of interoperability that we all know is necessary.
Erica, that's one of the things I'd like to hear your comments on. FHIR has certainly been implemented, but how much is it being used? How are the challenge of providers being trained to see the benefits and use of FHIR? What are your thoughts on that?
I love this question, Jim, because I would agree with Mickey. FHIR's been around for a long time, and more than 10 years ago, I was in federal service at ONC, and everyone thought FHIR was going to solve all the interoperability challenges the next year. And then, right, I know I'm in good company when I say that. And I do think progress within the EHR certification space has made a difference. The capability is out there. I will say really candidly, I think what we find is Mickey mentioned health plans and payers. There's probably more actual use that we see on the health plan side than on the provider side. A lot of EHRs have the capability. I also think a lot of healthcare organizations are very comfortable with HL7V2 transactions and CCPAs, even though they're big, bulky XML documents. And so we support it all. We do it all. I think we have to meet organizations where they are technologically. That's an important role for an intermediary like an HIE to serve in. I guess the other thing I would note that we've really observed is FHIR can be used for push transactions, but it may not. I don't know. I think there's a debate to be had about whether it's the best technical approach for actual push transactions, like ADT notifications, for example, when you're not querying to look for something or pinging for something, but and looking for a return, but you're trying to push information in a timely manner to a destination. We did use FHIR this year as part of the early adopter program for NCQA's digital content service. And that was also, I think, an eye-opening experience for us, really trying to take those FHIR packages, FHIR resources, and use those in an engine, a measurement engine to produce gaps in care. We learned a lot through that process. And I think our big takeaway probably on that front is the devil is in the details, as is always the case on technology and data standards. The devil's really in the details.
I'm sorry, go ahead, Mickey.
I just wanted to add maybe one thing to sort of what Erica was saying. I do think the HIEs have a really critical role in sort of making FHIR adoption more widespread, right? Because you obviously have sort of mandated FHIR support at the EHR level, and that's necessary, but it doesn't quite bridge the gap, right, to support all of the use cases that FHIR could enable. And so it's really the HIEs that are stepping into that gap, right? And they're getting data from all of these traditional sort of mechanisms that aren't FHIR, right? And then they're exposing that additional data through these robust FHIR APIs. So they are actually enabling a level of exchange on the FHIR standard that individual organizations and EHR providers are not yet capable of doing. So
Thank you for that. Erica, what advice would you give to HIEs looking to better serve payers? We don't hear as much about that as we do about the provider side, but what about the payers?
Yeah, that's a space that's near and dear
Yeah.
to our heart. I think there are a number of things that other HIEs and data intermediaries or aggregators can be thinking about. And my advice would be focus on the problems that are really hard for those health plans and payers to solve. So things like access to real-time clinical data. That's still something that health plans need. Claims still have a delay. If you can tell a health plan about something happening with their member before a claim hits them, that's really high value. I mentioned being a connector when we were talking about FHIR, being a connector, and Mickey also noted it across multiple different formats and exchange pathways. That I think is also a huge value to health plans. If they don't have an HIE partner to manage all of those disparate connections, a health plan has to do that on their own. And that's a huge investment. It's a huge investment upfront to build out that connectivity. It's also a huge investment to maintain it over time. So I think that's another space I would recommend folks think about. And then maybe I'll mention data quality as another potential sweet spot. Data coming out of one EHR is not the same as data coming out of another EHR, even when we use common implementation guides. Those of you who do this work know, just because we use the same implementation guide does not mean that our output is identical. And that creates duplication in some cases. It creates disparities in coding and use of code sets and value sets. And so I actually think there's another kind of sweet spot for HIEs in the data quality universe and thinking about uplift or normalization for health plans so that they can put that data to work.
Mickey, your thoughts about that? How the HIEs can better serve the payers?
yeah, I would say that HIEs are very much an underutilized resource when it comes to the payers, right? A lot of data out there on their members that is much more timely, accurate, and actionable than what they get through their claims processing, right? And we're starting to see more and more interest in the payer community to reach out to HIEs and vice versa, right? There's sort of a good sort of mutual benefit there, right? Payers derive direct monetary value from that information, so they can help to fund, all the good work that the HIEs are doing, and the HIEs, can, take this high quality data that they've invested so much into collecting and curating and, provide additional value, right, on top of that. I think that's happening today, although there's much more room to go. As we touched on kind of payers and their use of FHIR. As payers start to really evolve their use of some of these standards, this has been sort of one of the things that has caused friction. Like, payers have dealt in a very clean kind of world where claims data is very sterile relative to the sort of healthcare data that most of us deal with on a daily basis. So there's been a real learning curve for them to learn how to use this data and get value out of data that might not be quite as black and white as what they're traditionally used to. So I do think that some of the FHIR initiatives that they're involved in and are mandated to be involved in through CMS have required them to start to look at clinical data in ways that are new, and the HIEs are the best source they can get of that clinical data, right? So there is a lot of good stuff that's happening really right now around that, and I think will continue in the future.
Mickey, one of the things you mentioned there was I guess you hinted the financial stability of these HIEs. And I think that was one of the big problems with the precursors, the regional health information organizations. A lot of them went by the wayside, either from lack of use or lack of funding. There were some problems about that. Let me just say, in terms of TEFCA, here's what I'm looking forward to is when there is availability of the individual access, and I can have some type of software or third party that I give approval to, and they have and I can push a button. I want to see what comes out of that faucet for me. Now, where are we in? Is there individual access yet, or is that mandated by the QHINs? Where are we with that for individual access?
Yeah, I mean, there's there is the patient access API, right? Mandate, right, which is really something that's placed on the provider side, really on the certified EHRs, right? So this is some of the work that Mickey and his team are doing at the federal level, right, to require that providers can give access to patient data through robust standards. Again, FHIR is the platform used for that. And then on the payer side, there's also something we call CMS 9115, right, which is a similar attempt to mandate through CMS that if you're a member of a particular health plan and you want to access your own data through whatever application you want to use, right, they have to provide it through a standard API, again, a FHIR-based API. So if you're a Apple Health user, for example, you theoretically should be able to get both your data from your provider and your data from your health plan into Apple Health in a way that is relatively low friction. Now, I mean, that's the goal, right? I think the framework is there, that the standards are there, the federal requirements are there, right? I think we're just now seeing that play out. So I think I wouldn't call it low friction. It might be possible now, but it's not low friction. So as TEFCA comes on board and as TEFCA starts to focus on how do they impact patient access to data, right? How do that hopefully lowers the bar and it makes it even that much easier for the average person to get access to the data that they need, right? So they can take care of themselves.
I mean, that's a good point. I mean, we usually think of interoperability as maybe provider to provider, but as interoperability for patients. We only have about a minute and a half left in our session, but Erica, your thoughts about that patient access, that side of interoperability?
Yeah, I mean, I think it's critical. And I think that's part of why TEFCA incorporates it as a required response. It's part of the core set of initial use cases. I will say from an HIE perspective, we're typically a B2B type of organization, right? We're not usually working directly with consumers. MX does enable individual access, and we do it with a partner organization. One of the biggest challenges we encountered, because we are a B2B, typically a B2B organization, is identity proofing. How do we ensure we're dealing with PHI, right? And we got to be really careful about those disclosures. How can we ensure that the person who is requesting the record is actually who they purport to be, given we are not like a physician's office where we engage with an individual directly and can check their ID card or their driver's license and confirm their identity. We have found ways to partner with organizations like Clear that do remote identity proofing, and that, I will say, has opened up a whole universe of opportunities for us to be better about that individual access support service.
Well, great. Well, looks like we're totally out of time. Mickey and Erica, thank you so much for your comments today. Carol, we're going to throw the ball back over the fence to you, ma'am.